And so in 2004, 8 years ago, opened my first office endovascular suite, and that was real successful, and so it rapidly grew through 5 renditions until in January we moved to our new 8,000 square foot office where we have 2 endovascular suites and just hired another interventional radiologist last year, and we have 26 full-time employees. It's not that I have a lot of needs and I'm dyslexic and I need all these people. These people are actually doing a lot of work because we're running the OR and the clinical practice. And have a little video here that just shows you how efficient it is to, instead of going to the hospital and wasting a lot of time, you can run your office while you're also running the clinical practice. So we simultaneously run, with a nurse practitioner and PA, we run the front clinical part of the office. And we have an interesting lighting system you'll probably like. So this is me leaving the vein surgery room, turning my light off, and going to where my light's on. I know where to go because my light's flashing. And in that room, we do a consult with my nurse practitioner. Walk out, and they're waiting for me in the operating room. And so this is literally probably like 20 steps. And then this is some nice US magic where I'm going to go in the room here without any lead and come out in a few seconds later with my lead on. And then hop into the other operating room. So you can see why we really like the office. The patients love the office. The doctors love the office. Government likes the office. It's a lot cheaper. I think this is a model that other countries would probably be interested in as you know, trying to contain all these expensive healthcare costs. When you have your own office, you can do a lot of your own marketing, and so we spend a lot of time, like Ziehm, doing marketing, and that's actually a lot of fun. The way I decide what I do in the hospital is I basically do everything in the office, probably 98%, with the exception of some cases that require general anesthesia, like our AAA endograph repairs, maybe some patient who you think is extremely high risk that you want to do at the hospital. There's some procedures that aren't paid for in the office, but what's happening is every year a few more are added, and I'm actually on one of the committees that helps determine that. And so with time, there won't be any procedure that's not paid for in the office unless it's deemed too high risk, like carotid stenting for the foreseeable future will probably be a procedure that's only in the office. Most vascular procedures that used to be performed with open surgery can now be performed using minimally invasive endovascular techniques. Most of these can also be done in the office. Doctors would much rather do this in their office where they can run their whole practice, their clinical practice in their OR. Patients would much rather have an experience in an office. I think we have much higher quality because we have a group of nurses and techs who are focused on the patient. They don't care about ER patients and myocardial infarction patients. They don't have patients in other rooms they're having to take care of. So I think we do a very high quality care. And you know, you have to remember at the end of the day, these are the physician's patients, and it seems a little odd that they're taking them to the hospital for the hospital to make a bunch of money on their patients when they're outpatient procedures. And so, especially when money is so short and the healthcare dollar is shrinking, this is a way for, you know, the physicians to I think do better care, more efficient care, and also have some extra revenue.